All right. So the boss told me we have to restart. I know we're having a wonderful time visiting, and there's plenty more opportunity for this, but we need to move on. The next speaker is actually one of my former residents and students who I shipped down to Memphis for some polishing. Dr. Lou Magnotti. This trip to Memphis caused me no end of problems at Dr. Magnotti's wedding when I was berated for 30 minutes by his mother for sending him out of New Jersey. Correct? Literally, she came back. She kept coming back in the middle of his wedding, go back and forth and yelling at me over and over. How could I send him to Tennessee for all places? It worked out, I think, pretty well. Lou?
Thank you, Dr. Livingston. It is truly an honor to be included in Dr. Fabian's celebration today. I'd actually had a longer talk and cut it down because I thought people were sticking to the 15 minutes. So I'm going to throw in one story that I had cut. When I was a fellow in Memphis, my first day of fellowship was only the second time I had met Dr. Fabian. First time was at our interview. And for those of you who know Dr. Fabian, I make him look talkative. So by the time I met him for the second time, Dr. Fabian and I had spoken, well, the number of words you could count on one hand with fingers left over. But it was my first day of fellowship, and my co-fellow and my co-fellow was on the chatty side. We were in the offices in the Coleman building with one of the best program coordinators ever, Nancy. Dr. Cross, we were supposed to meet there, but he was at the trauma center working. So Nancy said, that's no problem. Dr. Fabian will take you guys to the trauma center. So we start walking to the trauma center, up the hill to the trauma center, and Dr. Fabian's talking to us, which was a little bit shocking. And he kept referring to me as Luke. That's not my name. And my co-fellow leans over to me and goes, he's calling you the wrong name. I said, of course, I know what my name is, shut up. And again, we're almost there. She goes, he's calling you the wrong name. Correct him. I'm like, I'm not going to correct him. So finally, when we get to the trauma center, we're right about to be dropped off to Dr. Cross. My co-fellow can't take it anymore. She goes, Dr. Fabian, you've been calling him the wrong name the whole time. His name is Lou, not Luke. Dr. Fabian just walked away. So that was my first interaction as a fellow with Dr. Fabian. And I was like, wow, this is going to turn out well. But seriously, to get into the talk, Dr. Fabian's almost compulsion with only the most challenging of clinical questions began early in his career. In fact, in his fellowship in Atlanta with Dr. Harlan Stone, Dr. Fabian already began by tackling a problem that vexes trauma surgeons today, and all surgeons, if you're in emergency general surgery, is the abdomen that will not close. There, he and Stone identified 167 patients over a 20-year period that had major abdominal wall defects. And these were primarily due to necrotizing soft tissue infections. This was followed closely by destructive abdominal wall trauma. And what he and Stone realized was that as wound management varied, so did outcome. And without exception, for those patients that underwent primary closure of the abdominal wall, it ultimately led to wound infection and necrosis with about an 85% mortality rate. And this was primarily due to undue tension on the abdominal wall. The addition of a pedicle flap while relieving the tension, they found, well, had the problems of a tenuous blood supply and greater exposure of surface area contamination, leading to an unacceptably high rate of wound complications. So together, they concluded that for small defects, which they defined as less than 8 centimeters, gauze packing alone was enough. It prevented evisceration and allowed for an acceptably low rate of wound complications. For more sizable defects, the authors decided that bridging it with a synthetic mesh would, 1, maintain abdominal domain, and 2, would allow gauze packing to be used again in a similar fashion to previously described, except in this case, to pack directly onto the mesh. Once evisceration was no longer a concern, skin grafting could take place then. So this study, which was now more than 40 years ago, the principles that were obtained form the foundation for a future simple yet elegant management scheme after some refinement on how to approach the patient with the open abdomen or the abdomen that will not close. Not surprising, then Dr. Fabian took what he had learned about the management of the open abdomen in Atlanta with him to Memphis. And in 1994, Dr. Fabian and colleagues in Memphis published an essential how-to manual in the Annals of Surgery. In it, the authors provide a comprehensive analysis of a stage management scheme for both the initial and subsequent treatment of these abdominal wall defects. And really, up until this point in time, no such published management scheme was available. In their study, the authors identified 88 patients over 8.5 years. And this is where the scheme comes into effect. In each case, the initial gap between the abdominal side walls was banned by a prosthetic. And initially, there were 3 prosthetics that were used. There was polypropylene, PTFE, and Vicryl for the simple-minded like myself, rather than polyglactin 910 that Dr. Croce likes to call it. And this was stage 1. It was also during this time, over the next several days to weeks, where as the patient improved clinically, as the edema resolved, the authors would gradually pleat the mesh at the bedside with the goal of bringing the fascial edges closer and closer together to attempt to attain delayed fascial closure. However, unfortunately, this is not always the case. Sometimes the patient doesn't get better. Sometimes the edema doesn't resolve. And for these patients, they entered what was known as stage 2. So after about 2 to 3 weeks of leaving the mesh in place, once granulation tissue had started forming and the visceral block was adherent, that the mesh would be excised, exposing the visceral granulated block, and then covered with either split thickness skin graft or full thickness skin, depending on the patient's habitus and what you had to work with. This then resulted in stage 3, which was the planned ventral hernia, which we're all unfortunately familiar with. 6 to 12 months later, stage 3 was followed by stage 4, or definitive abdominal wall reconstruction. And that we will go into more detail with. So in their study, the authors provide a detailed step-by-step technique for each stage of the acute management of these giant abdominal wall defects. And really in this study, this is the first time that Dr. Fabian describes his preferred technique of abdominal wall reconstruction. And if you ask him, really the only technique that should be used, the modified component separation. That technique is used to fix this problem. And in brief, we'll go through it. You initially wait 6 to 12 months, and the reason for waiting is you want the inflammation to subside and the adhesions to soften. The skin graft, you judge separation from the underlying viscera by seeing whether or not the skin graft is separating by pinching it, almost like your shirt would come off of your body. But there becomes a point of diminishing returns, and that's why the 12 months. Because after that time, you're really not going to get any more separation. You're really not going to get any more softening or lightening of the adhesions. If it's stuck, it's stuck. But what's going to happen is the lateral abdominal wall is going to continue to retract, making the repair more and more difficult. Hence, about the 12-month wait. Once you've now determined that you've either waited too long or the skin graft has had sufficient time to separate from the underlying viscera, the patient's taken to the operating room and the skin graft is excised. Initially incised in the mid portion, because you learn from Dr. Fabian when you actually ask him about this technique and have him teach it to you, which I can say for anybody that's trying to learn something, if you learn it from someone who's actually perfected it, it's really almost impossible to describe because of all the little nuances and tricks that Dr. Fabian knew and could pass along that really doesn't come through in any of the manuscripts. I mean, even the ones that I've been involved with writing, it's really hard to pass along the tricks and stuff that he's able to teach. But he'll tell you that you start in the mid portion of the skin graft. You're going to want to start on the edge because it seems like it should be, but that's always where the adhesions are the most and where they lighten up the last. So you get in and you start excising the skin graft off and you expose the underlying visceral block. The next portion is to then mobilize that visceral block, however you have to do it, whether you have to lyse all the adhesions, cut out the heterotopic ossification, but to allow the visceral block to be free from the anterior abdominal wall. Once you've done that, you create skin grafts, skin flaps bilaterally by raising the skin and the subcutaneous tissue off of the underlying fascia to expose it. Not only on the anterior rectus, but out beyond onto the obliques, because the next portion is going to involve anterior releases, where you incise the aponeurosis of the external oblique about 1 centimeter or so lateral to the rectus muscle itself along both sides of the wound. This is a schematic drawing that one of the late cardiothoracic pediatric surgeons in Memphis helped us with. He was a very good artist, but this shows the skin and subcutaneous tissue has been removed. And you can see the anterior rectus fascia. Here's the rectus sheath, and here are the obliques and transversalis as you get out laterally. So the next maneuver is making the anterior release, which involves division of the aponeurosis of the external oblique by both sides of the wound. The next step is the posterior release, where the rectus muscle and anterior sheath is taken off of the posterior sheath. Again, this is done bilaterally. At this point, you've really got as much release as you can without doing one more little step. The next step, if these muscles will not come together easily in the midline, is the Memphis modification. And that involves cutting of the anterior leaflet of the split internal oblique aponeurosis. which is there. This then, as you begin cephalad and continue it inferiorly to the arcuate line, almost completely detaches the rectus on both sides, except for where it's attached at the rib cage, and allows you to move it to the midline, almost doubling the amount that the component separation, the standard component separation originally described by Ramirez would give you. Your final product provides 3 suture lines. You suture the lateral edge, the anterior rectus, to the medial edge of the posterior rectus, out laterally on both sides, and you suture the rectus muscles together in the midline. The goal of that is to change this planned ventral hernia into this completed abdominal wall reconstruction. It's provides a very good out when the standard releases don't work. Well, it's clear that today we all know and we've all heard that Dr. Fabian loved to teach, and he loved complex clinical problems. But he was also one, or is one still today, to not rest on his laurels. He always wanted to make sure that the care he was providing for his trauma patients was optimal. And he did that by questioning what was being done at the trauma center. Dr. Weinberg and I have made jokes about redo studies, but redo studies are very important. You got to make sure what you're doing is actually working. And when I was a fellow, I met one of the lab residents. His name was Wright Jernigan. The lab residents in Memphis used to take call at the trauma center every Friday and Saturday night to help out, even though they were in the lab the entire year. And Wright was in Dr. Fabian's lab, and he was looking at the acute and long-term results of this management scheme. How was it working? And in this study, Dr. Fabian and his colleagues identified 274 patients, and they looked at them from the onset of injury to up to 60 months post-injury. On average, these patients had defects that measured 20 by 30 centimeters. And 157 patients underwent temporary abdominal closure, now with the mesh of choice, which was woven Vicryl. Yes, it's that specific. It's woven Vicryl. There's a knitted Vicryl and a woven Vicryl. And the woven Vicryl is the mesh of choice for your temporary abdominal closure as you're bridging to stage 2. As you can see, 37 had delayed fascial closure, but 73 underwent definitive abdominal wall reconstruction using the modified component separation technique. The mean follow-up was 24 months, but it ranged from 2 to 60 months. And the authors identified only 4 recurrences, which was a 5% recurrent hernia rate. So the authors have very nicely, once again, presented their consistent and effective staged approach to the management of these open abdomens and the reconstruction. In the acute phase, the absorbable mesh Vicryl provides a satisfactory coverage of the abdominal viscera, preventing evisceration, allowing for formation of the visceral block. Coverage of the granulated wound as soon as the viscera is stuck is important. And here I have to quote Dr. Kroos, because Dr. Kroos would tell you you have to be like Goldilocks here. You want to do it just right, not too soon, and you don't want to wait too long. Because as I learned from Dr. Livingston and when I was a resident, there's a foot race between getting this coverage and a fistula forming. And the sweet spot seems to be somewhere between 14 to 21 days. But you want to make sure that that wound has got some granulation tissue and that the visceral block is stuck. Thus, for definitive reconstruction, the modified component separation is the procedure of choice. And ideally, it should be accomplished within 6 to 12 months. Once the adhesions have softened, waiting longer doesn't add anything. In fact, makes it more difficult. Well, as with any academic career, it has to begin somewhere. And when I went back to Memphis, one of the easiest ways to generate a research idea involved one of the hardest things possible was to get Dr. Fabian talking. So one day we were sitting in Dr. Kroos's office having casual conversation, and Dr. Fabian happened to look up and said, a smart young faculty member might want to look at our abdominal wall reconstruction experience again, in the long term. I know we looked at it once, but I want to know how this is holding up. So I took that, hijacked one of the lab residents, and in 2009, at the Southern Surgical Association, Dr. Fabian, nearly 29 years after his first presentation on the subject, again presented on lessons he had learned and how well his repair was holding up in the long run. In this study, it spanned 15 years, 152 patients that underwent abdominal wall reconstruction for planned ventral hernias were identified. And as you can see, there's a mix of prosthetic use in these. 14 patients had delayed fascial closure, some with prosthetics, some without. 47 had just component separation with and without prosthetic. 91 had modified component separation with and without prosthetic. And follow-up was achieved in 114 patients. The longest follow-up was almost 15 years, and the mean follow-up was 5.5 years. What the authors found was that there was a 14% recurrence rate. Well, that seems a lot higher than the last study, except in this study, there was a lot more prosthetic used. And the prosthetic use itself increased recurrence by 4-fold. For the modified component separation, if you just looked at those patients that were reconstructed using the modified component separation without prosthetic, there were only 2 recurrences identified, which amazingly is 5%, which is exactly the same to the previous study. So, as Dr. Crow said, the data sort of holds up. It was 20% if prosthetic was used. And the predictors of recurrence, one was unusual and unexpected, and one was expected. They were female, gender, and BMI. The authors here concluded that for definitive reconstruction, modified component separation procedure of choice. It can avoid the need for prosthetics. And in fact, without prosthetics, it resulted in an acceptably low recurrence rate. But in the larger defects, there comes a time when after you've done maximal separation of the abdominal wall, you may still not be able to get it together. And that is when a bridging mesh may be used or may need to be used. And it was in those patients that tended to have the higher recurrence rate. So what better way to sort of bring things to a head than to write a final technical how-to article? And that's exactly what was done in 2012 with, once again, Dr. Fabian leading the charge. This manuscript was the culmination of his vision on how his technique for abdominal wall reconstruction should be written, presented, and disseminated. In it, the authors present a step-by-step approach to abdominal wall reconstruction, complete with diagrams, operative photos, pearls, and pitfalls. And this is just me going to summarize a little bit about the management of the open abdomen. You know, this topic tends to generate varied and often heated opinions. It's been suggested, not subtly by some, that Dr. Fabian and the Memphis group somehow worked to create open abdomens and failed to close ones that other institutions would routinely close. Despite these unsubstantiated rumors, delayed fascial closure remains the goal in all patients initially managed with an open abdomen, even in Memphis. But unfortunately, sometimes life hands you lemons. And if you don't know how to make lemonade, you're going to be left out in the cold. And at times, the staged management of these wounds is unavoidable. And God forbid I say it, an absorbable mesh may actually be necessary and useful. And in those instances where, despite all efforts, whether you've done judicious crystalloid resuscitation, whether you've done DPR, whether you've done balanced resuscitation, taken the patient back, used the Widman patch, used sequential fascial suturing, where none of that seems to work, what Dr. Fabian has proposed offers a simple approach to manage what can be an overwhelming problem for those that aren't used to taking care of it. And 40 years later, this approach and management scheme that was proposed by him has stood the test of time and provides an out when nothing else will work for you. As a former fellow, faculty member, and partner to Dr. Fabian, it was an honor and a privilege to have been trained by him and to work alongside of him. His teachings, thoughts, and actions have helped shape the care of the modern trauma patient. And if I may paraphrase a line from one of the greatest movies ever made, Top Gun Maverick. Thanks to Dr. Fabian's influence, I am a trauma surgeon. It's not what I am, it's who I am. Thank you, Dr. Fabian, and congratulations on an unmatched and unparalleled career.
What do you guys see numbers wise compared to what you saw 15 years ago? I mean, I can't imagine that you're seeing the same volume of this clinical problem.
Memphis? No. I mean, it's gone down. And clearly it's the balanced resuscitation. And when I was a fellow in Memphis, one of the attendings challenged Dr. Streck, who's the program director in South Carolina, I think, Charleston, to resuscitate the patient enough. And Dr. Streck gave that patient so much fluid that he went from normal sized to lips swollen about that much down to his teeth. But yes, like they're different patients nowadays. But I think this is an important thing to keep in mind because there are occasional patients that you can't get closed. And it's unfortunate because it's not that difficult a problem. It's something that if you follow the step-by-step approach to it, it can really be handled quite easily. But unfortunately, it's not as common as it used to be, correct? Yes. Thank you.
Up the skin graft, that was a sign that things had separated from the skin graft itself. There was also an implication that that would tell you what the adhesions would be like. And I can state after doing many of these, it has no correlation whatsoever.
No,
And
no, it gives you
I hope Jennifer and your article in 2012 stated that because that misconception is common among residents and fellows. There's no correlation. Some of the worst adhesions you're ever going to get are clearly in people you can lift the graft up. It doesn't tell you that.
No, it does. It does give you confidence that you can at least get the graft off and start the operation because otherwise it's without that initial plane, it's really hard to begin. But yes, it doesn't. But again, after a year, it's not going to get any better. And I've done a lot of these after a year because people are afraid to tackle it for that reason. They're afraid of the intra-abdominal adhesions and keep putting it off. And at some point in time, someone has to bite the bullet, as Dr. Cross and Dr. Fabian have always taught to reconstruct these people.
Well, there's no question the intra-abdominal adhesions away from the graft, that's not a bundle of joy, but it will tell you you'll get the graft off of the guts that are right underneath it. And, after you've done a few of these skin graft removals, you do pick up little tidbits, as you were alluding to, that you sort of understand the plane to get into. But if you aren't careful and you go back too soon before you can pinch it away, you're going through real hell then. And then you end up with bowel injuries and back in where you were before you started the operation with fistulas.
That was great. Two questions, Tim. One question through a little bit. Why did you start in the when I did these, again, following your thing, but I started with the skin flaps first because back in the early 80s, the anesthesia would just flood these patients. And if I started with the viscera, the skin graft first instead of the flaps, it always seemed to get a lot more swollen. So I'm just curious, why'd you go inside versus doing the flaps at first? Because I do my flaps, I just had a thing, I do my flaps first, and just kind of the thought.
Oh, you mean no graft, just mobilize the skin off the?
Yeah, I did the flaps first, packed them to get them hemostatic, and then I went to the abdomen because anesthesia understood that they weren't gonna like flood the patient with crystallite back then.
Yeah,
Again, these are the 90s.
For some patients, before a lot of edema develops, I think that's a good idea. You can avoid it, but resuscitating and following them for several days, and then it gets almost impossible to get what you're talking.
No, I'm talking about when you do the abdominal reconstruction.
Oh,
I just did the skin flaps first and then went into the
Right.
abdomen. Just for that, just out of curiosity. The other thing is when you did this with Harlan, right? I mean, they actually, Ogilvy and people wrote about putting like bridging canvas. And then that, like a lot of things in World War II, was quote unquote debunked. And I remember literally, the joke was, you could get anyone closed if you put your foot up on the operating table as a resident. That we did not do them any question. So what the genesis of this bridging thing is the necrotizing infection patient where you had no abdominal wall left, and to use it in the trauma patients? I'm just kind of curious how we came about with that, because that was sort of, again, somewhat heretical back in, I guess, their 70s, whatnot.
yeah, I think the largest experience when first published, when Dr. Stone and I worked with him on it, it was necrotizing fasciitis, which I don't know what happened to necrotizing fasciitis, why we don't see it like we used to, but it used to be very, very common. Maybe it was closing contaminated wounds and getting infected that way. But, then he stumbled onto the Proline mesh because Proline mesh was developed and marketed, I guess, around 1980s or 75 maybe. And it became apparent that that would be the best available prosthetic at the time. The problem with it was, of course, is we and others learned that there's a certain number of those patients, it erodes into the damn bowel and you got serious problems with fistulas. It doesn't happen on everybody, but for several years, what we would do before we got onto the vicryl mesh was take them back there 2 to 3 weeks and scrape all that damn granulation that was coming through the Proline. And that was a really painful procedure. It took a long time, and you would occasionally, of course, get bowel injuries, and those weren't easy to fix once you got them in that situation. So I guess I learned whether in the end I advanced to science or not, I don't know. But I learned a hell of a lot about managing these complex things. And it's like many things in life. Sometimes you learn more from your mistakes than you learn from your successes.
Oh, yeah. There's a question for Dr. Magnotti, or Dr. I think from an online reviewer. So question from the internet. The next version of this, laparoscopic, robotic, what is it? Where does this fit in? Or does it fit in?
If someone can do it robotically, more power to them. I can tell you that, and a planned ventral hernia is different than a dehiscence. And I've gone to where patients have dehisced and lost abdominal wall. I'll do this reconstruction, but then I do a mesh onlay. Even in contaminated fields, I use a wide pore polypropylene mesh. But for those patients, those other patients, planned ventral hernias that have never had failure of their abdominal wall, that their fascia is their fascia, I don't think you need to do anything to reinforce those patients. But if someone can do it laparoscopically and robotically, that's great. I'll give them all mine to do. That'd be fantastic.
Lou, awesome talk, as usual. Haven't done a few of these things with you. The one thing that's a complicating factor is having an ostomy. And so I think just, for people that are listening or may review this talk later one day, do you have any management techniques for how you deal with, somebody you're doing a component separation on who has got an ostomy you need to take down at the same time?
Well, I've had, having been both in Newark and Memphis, there was 2 different philosophies. Like Dr. Livingston, and I learned from Dr. Livingston, you could take down the ostomy through surgical sneaking and do that as a separate procedure. So you'd go back and have a clean field. And then when I suggested that to Dr. Croce, he said, "How would you do that? Just do it all at once." So I've done it both ways. In fact, when Dr. Fabian presented Dr. DeCoco's work at the Southern Surgical that year, having an ostomy was actually protective against a recurrence. I don't really like talking about that because I can't really explain why, but now I fixed the ostomy site as part of the repair. I think if you're going to have an ostomy and you think the patient may be open, a little trick that I learned early on from Dr. Livingston was to make the ostomy lateral so you don't fuck up your rectus sheath. Excuse my language on air here. But you want that so you can do your reconstruction later. And even those patients that have ostomies that have then had lost abdominal wall and dehisced, done the onlay in those fields and have had success with it. So.
I just want to hijack this conversation because it made me think of a story. When I was a third-year resident, there was a patient that needed a cholecystectomy. And my chief was down in the trauma operating room doing one of these, taking out this proline mesh on a patient. This is before we got into the Vicryl. So you take the patient, as Dr. Fabian said, and you would take the tail end of the knife handle and scrape off all the granulation tissue and then dissect off the proline mesh. And that was not a quick and easy case. So I've been sitting on this gallbladder because I wanted to do it. And I got Dr. Fabian to help me do it. So we're at the scrub sink and he said, all right, tell me about this gallbladder. I said, well, I may have forgot to tell my chief that bilirubin's up and alk phos is elevated. So we're going to have to do a cholangiogram. And he cut his eyes over at me, kept scrubbing. And he said, have you ever done a sphincteroplasty? I said, no. So short story is we take this patient to the operating room, do the cholecystectomy, shoot the cholangiogram. She got an impacted stone, which I knew she had a stone. And he helped me do my first transduodenal sphincteroplasty, but never ratted me out to the chief. Never ratted me out, even though I knew I was going to get to do a bigger case, and my chief was stuck grubbing out this piece of proline mesh. So it was a great case. Thanks, Tim.
That tells you all you need to know about Dr. Croce.
I don't know how we got to transduodenal sphincter, but Dr. Fabian did. I also did my first transduodenal sphincteroplasty with Dr. Fabian. So he's teaching the world how to do an operation. All right. Thanks.
Luncheon is served
We never figured it out. Yeah, we were
outside,
dumbfounded.
but not that far outside.
We thought maybe it somehow could be related to childbearing, stretching out the